Welcome to this OR Live webcast, live from Christiana Care Health System in Newark, Delaware. OR Live, the surgical broadcasting company.
Hello, welcome to Christiana Care. My name is Mike Rhodes. I am Chairman of Surgery here at Christiana Care. Today we're going to have the opportunity to observe a minimally invasive parathyroidectomy performed by Dr. Raafat Abdel-Misih. Dr. Abdel-Misih is the Vice Chairman of the Department of Surgery and a specialist in head and neck surgery as well as hepatobiliary diseases. Dr. Abdel-Misih has performed well over 1,000 parathyroidectomies in his career, but recently a technique has emerged which is called minimally invasive parathyroidectomy. The big difference here is we used to have to take out the parathyroids by making a ear-to-ear incision in the neck to do it, but now with some of the technologies that we're going to discuss, the ability to do this through a much smaller incision, in fact about 1.5 inch incision, really has facilitated this procedure. I do have a few PowerPoint slides here I think that will help explain some of what I'm talking about here. The parathyroid glands, there are 4 of them in the neck. They rest just behind the thyroid gland. They're separate from the thyroid gland. There are 4 little glands, maybe the size of a large piece of rice. When you look at what they can do, they're very important for the metabolism of calcium. Calcium is important to our nervous system. It's important to our muscles. It's important to our bones. There's a hormone that is released by the parathyroid called parathyroid hormone. This hormone is very important in our calcium metabolism. When the parathyroid hormone is released from the parathyroid, it actually pulls calcium out of the bones. And that's a normal function. That's how our calcium and phosphorus works every day. Once in a while, in about 100,000 cases a year, as a matter of fact, the parathyroid gets a little too enthusiastic, and one of the glands, very frequently one of them, forms a tumor, which is benign, called a parathyroid adenoma. What this basically does is juices up this parathyroid hormone, and the levels go up, and it causes all sorts of symptoms. The symptoms of this, in medical school, we're taught a little phrase about hyperparathyroidism, which is called bones, stones, moans, and groans. And the reason for that is what happens with the high parathyroid hormone is you lose calcium from your bones and you get osteoporosis, plus you can have bone pain. Because the calcium levels are elevated in your blood, it precipitates out in your urine and you get kidney stones. It also causes depression. It can cause a short fuse. Fatigue is very common. Abdominal groans comes from pancreatitis, which can happen with high calcium, as well as ulcers. By far the biggest symptoms of hyperparathyroidism is fatigue. Frequently a poor appetite that goes with it, depression, aches and pains, and people just don't feel right. These are the most common symptoms of this. The patient, Dr. Abdel-Misih's patient today is a young woman who actually has had high calcium for about 2 years. And her symptoms started mainly because she got kidney stones, and she's had some of the other symptoms that we talked about. One of the breakthroughs in technology over the past decade has been the emergence of a scan that's called sestamibi scan. Sestamibi is a protein, basically, that is attached to a radioactive, it's technetium-99, and it's taken up by the parathyroid gland when it's overactive. Here you can see on this particular patient, there's a scan. I'm pointing to. In the middle there's 2 little dots. These are the thyroid glands, and right underneath the left thyroid is a parathyroid adenoma. That's what the tumor looks like. And then this is another image, a little different type of an image, but shows the same type of thing, where you can see the 2 thyroid glands, and right on the bottom of the left one is the parathyroid adenoma. This tells us and Dr. Abdel-Misih where that adenoma is, and helps direct him toward that. What Dr. Abdel-Misih will do is make about a 1.5 inch incision, and he'll get to the thyroid through there. Before we start, he will draw some blood and to measure the parathyroid in the patient's blood system. And then when he actually sees the parathyroid, he will do it again, draw another blood sample. And then after he takes the tumor out, 10 minutes after that, he'll draw a third blood sample, which we'll send to the lab and make sure that the parathyroid hormone in the blood has dropped at least 50%. That tells us that the operation has been a success. Now, before we move to the operation, I want to mention that patients at Christiana Care, before surgery, every patient goes through a checklist. We call it the surgical safety checklist. This has been published by the World Health Organization, and it helps us just like the airline pilots. They use it every day before they take off in the plane. We now use it in the operating room. Dr. Abdel-Misih has already done the first part of this, which is before the patient is put to sleep. And then you'll see the second part of it, which is right before the incision. And then at the end of the procedure, they huddle together to make sure that they are all on the same page, the operating team, so that they can transfer the patient safely to PACU. So with that in mind, let's move over to the operating room and talk with Dr. Abdel-Misih.
Good evening. I'm Raafat Abdel-Misih, and I'm the lead surgeon for the team today. I'd like to introduce the team of the operation today, starting from my assistant.
Dr. Chris Snyder, the chief resident.
Michelle Kelly, physician assistant.
Christine Zanchuk, scrub tech.
Irene Foraker, circulating nurse.
Sorry.
Dr. Bruce Wales, anesthesia.
Mark Loftus, CRNA.
So the operation we'll be performing today is on NF. That's the initial of the patient, and the date of birth is 8/16/84. The operation planned is the minimally invasive left inferior parathyroidectomy, and patient position will be supine, but we also going to place him in reverse Trendelenburg position. The operation site is on the left side of the neck. We will also anticipate no critical events in the case. There is no need for anticoagulation, and we will have the steps of the operation involving collection of specimen for frozen section, as well as blood samples for PTH assay. The imaging studies are displayed as Dr. Rhodes have shown in the last few minutes. And the length of the operation is probably estimated to be about half an hour. No expected major loss of blood in this case.
Patient's ASA classification is class 1. There are no specific patient concerns. We have intravenous access and an arterial line for drawing the growth hormone assays.
Do you have any equipment issues? No equipment issues. Okay. Our overtime in the room is 16:41, and our induction time is 16:50. And our fire risk assessment is a 2, and that's our timeout complete.
Thank you. So I'm going to commence the operation. This is done through a small incision in the lower neck. We look for a crease line, and I'm going to put a mark on it. The estimated incision vary between 3 to 4 centimeters, depending on how the patient built. And we're going to start ahead. Take a knife, please. So using 15 blade, we're going to go through skin. And we tend to use the electrocautery. I recommend that we probably, on the skin, just to use cutting current. And use a pure cutting current to minimize tissue coagulation, especially on the skin. We use the coagulation mostly for bleeders. We expect to go through skin, subcutaneous tissue, and then we're going to encounter the platysma muscle. We try to just go through the platysma. I'll take a hemostat. So we essentially pick up the platysma and come across it until we reach the investing fascia of the neck or the deep fascia of the neck. We try to stop at that level because if we actually go deeper, we could encounter some bleeding from the anterior jugular vein. So we avoid that by sticking to the proper plane. Once we get through that layer, we will be able to elevate the flaps. The flaps are composed usually of platysma and subcutaneous tissue, as well as the skin. Our aim is to try to reach the thyroid cartilage, Alice's. We aim to reach the thyroid cartilage superiorly and the sternal notch inferiorly. So I'm going to create the superior flap, and to do so, atraumatic, we use traction counter traction technique. If the incision is big enough, we usually use the finger for traction counter traction. But sometimes the incision is quite small. We can use a pickup just to pull on the fascia. But it's important to keep that technique going. And sometimes, once we get into the proper plane, just simple blunt dissection by pushing in an upward direction moves the operation much faster and less traumatic on the tissue. So the upper flap is being formed, and we're up to the thyroid cartilage, which is about here. And now we're going to move in a down direction. And probably Chris is in a better position to do so. So we'll hold. You can take a debaki.
So Dr. Abdel-Misih, the reason to make these flaps is even though the skin incision is small, it allows you more room once you're inside.
Exactly. As you know, Mike, the advantage of in the neck, you can literally through a small incision move around in upward direction sideways. So you can start with a small incision, and the flaps would allow us to have bigger access actually inside. As you know, this operation obviously at one point was thought of to try to minimize it more by simply making an incision on the side where the adenoma is and kind of do blunt dissection down to it. The disadvantage is that you don't really have good visualization, and there is a risk of injury to the recurrent nerve. So we try to do this in a way so we can see anatomically the self-retaining retractor. Anatomically, everything we want to do. The bigger one also. I'll take a right angle. And a tie. 3/0 tie. So if you encounter any bleeding from the anterior jugular vein, simply we just tie them, because it's not easy to cauterize it. The flow is too high in that area. We have the bigger self-retainer. Need the short one. All right, so we now have exposed the investing fascia of the neck, and we're going to enter using 2 Addison forceps and a hemostat. You can. So the anterior jugular help us. In her case, you only have one small anterior jugular, but we could see the raphe in the midline, which is usually a little bit lighter because underneath it there is fat. That's compared to the area where you have the muscles. It's a little bit darker, so that's what we target. And we seem to have hit the midline exactly. And we target the midline because it's the least vascular area. As you know, in the neck, blood supply comes from lateral to medial. So midline is usually the last area fed, and the crossovers in the neck is minimal. You'll see some crossover veins, invariably small and not difficult to handle. So we're as high as we can here, and we'll go down again.
It's always impressive how much you can see and how much you can dissect, even through a very small incision.
That's the advantage of you're right, the neck. Even in moderately obese patients, the skin in the neck moves around quite well. Mm-hmm. So as you see now, we went through the midline fascia. And now we're looking at strap muscles, and obviously anatomically those strap muscles are the sternohyoid, which is the one on the top, and further down we're going to encounter the sternothyroid, and we go between those, now exposing the isthmus of the thyroid. We're also down to the trachea already on this dissection here. So we're on the trachea. We're going to now direct our attention to the left side of the neck to identify the parathyroid gland. So now we need different retraction now because we need those muscles. So my assistant's position is going to change. So I have Michelle come up to the top. And we'll take the green retractors, or Cushing's retractors. This is what we use for retraction of the muscles. So Chris is going to handle the cautery and the Becky forceps. And I'll be working with the right angle clamp. And use finger retraction, but if the space gets smaller, I switch it to another forceps, or sometimes what we call peanuts, just for retraction. Now the aim of the dissection of muscles here, I found the easiest way to do is that focus on getting the muscles off all the way laterally till we reach the carotid sheath. That will be the field of dissection which we will hopefully find our parathyroid. So now we're slowly moving the muscles away. And we have reached the area of the... And actually, here is the muscle down here. We suspect, based on that system EB scan, that this lesion is likely in the inferior position, inferior parathyroid. And here it is. If focus would see this lesion, which seemed to fit very much with the appearance of parathyroid. So we have taken the baseline. So now we do another taking of what we call pre-excision PTH level. So with regard to PTH, we do one baseline once the patient is asleep before manipulating the neck. And then the second one we do just before taking the gland. Yeah.
So now, Dr. Abdel-Misih, you're actually moving the the left thyroid, pulling it toward the middle, toward the medial aspect, so that you can see the parathyroid.
Exactly. I'm doing it medial and a little bit superior because I want to bring the gland in an upward direction, and as you know, it seemed to have some attachment to the trachea, so if I pull on the trachea in an upward direction, it will come into view much easier. So that's what I'm doing. And you can see it has a very good exposure to it.
So now you're continuing to mobilize the thyroid a little bit more.
Exactly. We're mobilizing the parathyroid at this point, and one likes to see a space between the thyroid and parathyroid, because although parathyroids at times have been discovered intrathyroidal, but if you want to make sure that it is the thyroid, the parathyroid, you want to see that there is a little bit of a space between them. And it seemed to have a reasonably good space at this point. So far this is our target, we believe is the case. So we're going to...
Dr. Abdel-Misih, in your experience, how frequently does the parathyroid come into view that quickly for you?
Yeah, not commonly. The inferior one, as you know, tends to be in an anterior position. So if I answer it correctly, I would say most of the inferior can come in view pretty quickly. It's the superior gland which tends to be more deeper in position and less likely to come so easy, if you will. One always has to be cautious about the quick interpretation, because microfollicular adenomas of the thyroid can look like parathyroid. So at this point, once we take that out, we're going to take some measurement, but also going to make sure that we got the right one. We'll take probably another look down further, but it seemed to be corresponding with the location of the parathyroid, and I almost see a kind of a normal parathyroid gland in one side. That's one of those pathognomonic for adenoma, because as you know, hyperplasia, you really would not see a normal gland. The whole gland is hyperplastic. But we talk about gross identification of adenoma is that when you see normal parathyroid, and arising from it is a larger nodule, and that's usually good diagnosis for the adenoma diagnosis. Because habitually, when we send it for frozen section, the pathologist will not say this is an adenoma. They will only say it if they saw the normal parathyroid. And I want to point this looks like a normal parathyroid gland here.
Right.
And then, if you can see that, well, the attached part, hopefully that's the parathyroid adenoma. So I think we're going to go ahead and take it out. So Chris will hold it from down here. Chris, go ahead and come across. One of the things we watch for, obviously, is especially if we're in the back of the gland, to make sure that we're away from the region of the recurrent nerve. So the relationship of the recurrent nerve to the parathyroid, that has to be kept in mind. I'm going to clamp here. A knife.
So commonly the recurrent laryngeal nerve runs posterior or behind the inferior parathyroid.
That's correct, exactly. It's so we probably will be able to show. Actually, we can see the nerve already. I'll show you that soon. Now, in 10 minutes, which would be 35, we would take the third specimen, and then send the sample down.
Could you, I know you just have removed the tumor. Can you,
I'm going to,
you still have a little stock
one
there,
attachment,
yeah,
and
right.
it will be out, and I will try to put it in view. It seemed to be attached to what we call the thyrothymic trunk, which is down here.
In fact, sometimes the inferior parathyroids migrate down into the thymus.
That's correct, and that's, I'm going to use this opportunity to just check the thymus here, make sure nothing hidden in it, or that gland does not extend down to it. So this is the the left thymic horn, and you can see here that it extends directly from the thyroid down into the chest, into the thymus. And because of the location of the parathyroid on the scan was somewhat inferior, I want to make sure that it's not hidden within that region. Okay, we'll take, I don't see anything in the thymus area here. Now here is a sample, here is this. So this is the specimen. So this is what we believe is the parathyroid adenoma. This little small thing on the end is part of a normal parathyroid, and this is the thyrothymic trunk.
Right.
We're going to send that for frozen. And we were just going to do some housekeeping, make sure it's dry. Left inferior parathyroid, yes. All right, here is the nerve. I think we have a, very well. We'll take some irrigation. So it's the overhead is on. This is the lower pole of the thyroid. Lower pole of the thyroid is here. This is what we tied. Part of the parathyroid is here. And here is the nerve, the whitish structure.
Right.
And has the characteristic little vessel which runs.
It looks like a little red racing stripe.
There you go.
So is it your practice, Dr. Abdel-Misih, to always identify the recurrent laryngeal nerve in minimally invasive parathyroidectomy?
Yeah, exactly. Especially if it's in the location of the nerve. It's, for example, if the lesion is way up on the front and far away from the nerve, and there's a lot of tissue on top, we don't have to go and look for it. But every time removing parathyroid, if I'm removing the inferior, I'll have to look behind it as I'm dividing the tissue behind it. And vice versa in the superior position. So the dissection, always in mind, make sure that there is no nerve structure coming close to the gland. And at times we've seen it very much hugged by the gland, so we have to separate it very slowly from it. So now we simply going to be waiting for frozen and the parathyroid hormone levels.
Well, if I can make a few points, Dr. Abdel-Misih, you're going to send the third sample down 10 minutes after you remove the gland.
Right. I think we took it out at 25 or 26, and so in about 6 minutes.
And to be certain that is the parathyroid adenoma, we would expect that third sample is at least 50% lower in the parathyroid level than was the second sample that you took.
That's correct. That is correct.
Now, a couple of other just teaching points for my edification. I noticed that you pointed out that when you saw this parathyroid adenoma, that you saw a little piece of normal parathyroid with it. And in fact, you indicated that that's actually a good sign that that's the adenoma.
That's as you know, the two conditions where we see hypercalcemia is either adenoma or hyperplasia. Very rarely we see carcinoma in parathyroid. And the distinction between adenoma and hyperplasia microscopically is very difficult. because they look alike. They look like it's hypercellular. There is not much fat under a microscope. But the only way to tell for sure, or close to being sure, is showing normal thyroid gland and then adjacent to it what appear to be hypercellular or very cellular gland. That usually confirms the diagnosis of adenoma.
And the second point was that this appeared to be attached to the thymic gland, and it prompted you to inspect the thymus to be sure that it didn't extend down into the thymus.
I agree. That is true. Now, if one puts the finger, you'd see that the dissection literally went down retrosternally. Mm-hmm. That's where the thymus is always located. Right. So we will be in waiting time. I'll probably come in and join you, maybe check on some...
Well, very good. I'm going to, now we're going to take a look at the, what happens at this point. The specimen that Dr. Abdel-Misih is talking about goes to the lab for an analysis, and we have a tape of what that really looks like. And I'm going to introduce Steve Johnson, who is a clinical biochemist who works with us at Christiana Care as part of our team for this particular procedure. And Steve is going to describe what you're looking at on this tape of the analysis.
Here we have a view of our technologist pulling the specimens off of a dumbwaiter that runs directly from the OR down into the laboratory 2 floors below. Our technologist puts the specimens into a centrifuge to separate the plasma from the red cells that are in the tube. And she goes over to the computer and logs the specimens into the computer so that we can identify each specimen, and the results of the testing is directly entered into the electronic medical record for the patient. Here the technologist is attaching the barcode labels that she's printed and put on the specimens. She's taking the caps off and putting the specimens into sample racks that will later go on the instrument that we use to process these specimens. She's careful to make sure that the identification of the specimen and which specimen it was, whether it's the pre-incision or the post-excision specimen. And here she's loading it back onto the instrument for the instrument to begin the processing. At this point, the specimen goes onto the instrument, and the instrument is reading the barcode label that is on the tube so that the identification of the specimen and the testing that is being done on it goes directly onto the instrument and then directly into the patient's electronic medical record when the testing is completed. Here are some of the movements that the instrument is doing to pipette the specimen and to add antibodies and a tracer molecule to it and incubate it for a period of time to allow an antigen-antibody reaction to take place. Later on, at the completion of the testing, the results will go directly electronically to the patient's electronic medical record. We'll also print out on a printer that is adjacent to the instrument, where we'll be able to view the results and check for any error codes that might appear on the final report.
So what we're looking for, again, just to repeat, we're looking for the third specimen that Dr. Abdel-Misih took after removing the parathyroid gland to make sure that using this cool technology that we're looking at here to look at the parathyroid hormone to make sure that the reduction in the patient's blood is at least 50% of what it was before we looked at it initially. Steve, thank you very much.
Thank you, Dr. Rhodes.
All right, we're going to now, Dr. Abdel-Misih has joined us, and we're going to be able to answer some questions that you have presented from email, and I'll start with what is the rate of occurrence for nerve damage during the minimally invasive procedure? And I'll let Dr. Abdel-Misih answer that question.
The occurrence should be well under 1% because the amount of dissection we do is less than the conventional neck exploration which entails working on both sides of the neck, working on 4 parathyroids. So we actually work on only one gland. And as you see probably from the operation today, we still do a classical entry into the neck. So we're following every anatomical plan. So as when we exposing the gland, we do see the structures around it. So it should be under 1%.
Another question here is, what is the normal PTH and what are normal calcium levels? It depends on what lab you use. Sometimes it's measured in milligrams and sometimes in nanomoles, but in our particular lab, the calcium level normal is 10.5. That might be different from lab to lab, but your primary care physician will certainly know that and be able to tell you if your calcium is elevated. The parathormone level should be no higher than 65. We also have a question here about can a parathyroidectomy be done through a laparoscopy or endoscopy? And I know there's been some attempts to do that. Dr. Abdel-Misih, is that emerging?
Yeah, it has been attempted. Japanese have worked on parathyroidectomy using the endoscopy, also using technique where you insufflate actual air into the neck, make a space, similar to what we do in laparoscopy for the abdomen or thoracoscopy for the chest, and work through that and remove the parathyroids. It does have some drawbacks, is that insufflating the air into the neck does not contain the air in the neck. It seems to travel, and most of patients would develop considerable amount of what we call subcutaneous emphysema. It's kind of frightening and it takes a while to go away. It does also still entail making an incision. So it is a smaller incision, however, it does require a considerable amount of dissection, and visibility is not as good as what we currently practice. So it's something, I guess, to be awaited for. It didn't pick up, meaning not many people have picked the procedure to do. Invariably means that there's some difficulty with it. But stay tuned. It may come up with better technology. We don't know as yet.
We have another question here on how do you find a parathyroid specialist, parathyroid surgeon in the area that you're in. My first response to that would be your primary care doctor is your best resource for sure. But another resource is an endocrinologist. An endocrinologist is a medical doctor who specializes in diseases of the endocrine glands, of which the parathyroid is one. And they usually know. They can guide you to the surgeons that specialize in this area, because the surgeon experience is directly related to outcome in this area. Dr. Abdel-Misih, any comments on that?
No, I agree. I think the primary care physicians invariably have gone through seeing patients with this disease. They would recognize who is practicing it and who is doing it on a regular basis, and they will help you through the referral. The same for endocrinologists.
Another question. I had a patient suggests, this is from Texas, I had a parathyroidectomy 3 years ago, and he wants to know whether or not the symptoms of high calcium will require another parathyroid surgery should his calcium level come back up. I think he's trying to find out what's the likelihood of recurrence once you've had a parathyroidectomy for this procedure, for this disease.
The chances of having another adenoma in the neck in a patient who've had previous parathyroidectomy is probably under 2% in the lifetime. So if the serum calcium in your routine checkups once a year have shown that the calcium is elevated, you should undergo the routine checkups which we do for parathyroid, which include checking your PTH and sometime urine calcium. And if proved to be that you have a second adenoma or elevation of those levels, then you should consider also having a second operation. But not everybody who have high calcium is related, by the way, to parathyroid. There is other disease process which cause calcium elevation, so it had to be sorted out by what we call a workup or investigation.
We have a question here on how high does one's calcium have to be for a person to need surgery? And we might use that opportunity to talk about the NIH criteria for asymptomatic patients.
Well, now, asymptomatic patients is a patient who, on routine labs with his family physician, let's say once a year you get your routine lab, serum calcium was found to be elevated. And in close questioning, the patient does not have any symptoms, meaning no history of kidney stones, no bony aches, no joint pains or aches in the muscles, no ulcers, no pancreatitis, all the things we look for which is associated with hyperparathyroidism. So we classify this patient as asymptomatic patient. Well, it's not recommended to operate on everybody who have elevated serum calcium. So the NIH has had 2 consensus conferences with about 8 years apart, last of which was in 2003, in which they established criteria for which patient should undergo this operation. And they have 5 criteria. Patient with total calcium level over 11 is considered for the operation. Patient who has a urine calcium over 300, and also patient with osteoporosis, where the bone density shows that the T-score is under 2.5. Also, if there is deterioration of creatinine clearance, something to do with kidney function, if the kidney function is deteriorating, and also it is considered for patients under 50. So these are the 5 NIH consensus recommendation for the operation.
If there's a number of questions here about some confusion between, and this is pretty common, by the way, between the thyroid gland and the parathyroid gland, because they almost have the same name. The para just means it's beside the thyroid gland, but they have 2 different functions. There's several questions here about if you have a disease of one of the thyroid gland, does that mean you're more likely to get disease of the parathyroid gland, or vice versa? Is that an issue?
It's more of a coincidence. There is only a group of patients who may have high risk for diseases in both glands, and those are the patients who have received radiation to the neck in their lifetime. Radiation to the neck increases the risk of thyroid cancer, but also increases the risk of developing parathyroid adenomas. So apart from that, there is really coincidentally, there is invariably diseases in both glands. And it goes back and forth, meaning, let's say we would explore a patient or do a patient for parathyroid is not unusual. In about 20% that we would find a nodule in the thyroid, or more than one nodule. And you have to decide at the time of the operation whether we need to address that or it's something to be watched. So there is at times what we call concomitant operation. We know it because we have ultrasound showing nodules in the thyroid. We have other process of investigation showing 2 diseases, so we prepare for the operation. But there is still an incidental finding at operation. So in answer to the question, while there are 2 separate glands, it is not unusual to have problem in both of them. And I would estimate it between 10 and 15%.
There's a question, they want to know if it's, there was one viewer wanted to know if it's true that the patients actually stay less than a day after the surgery.
If the operation is in the early morning, we could allow the patient to leave late in that evening. We would prefer to watch for at least 6 to 8 hours, and that's to really check for bleeding post-op. Checking for calcium is another issue, but that only affects a small number of patients who could develop what we call hungry bone syndrome. And you can tell those by checking their alkaline phosphatase pre-op. If they have elevated alkaline phosphatase, it's one of the enzymes we check in the body, then you may want to keep them and watch for hungry bone. But in answer to the question, yes, we can let them go the same day if it's early operation, but late operations, as today, we probably would prefer to watch the patient overnight.
Okay, we did get the frozen report back, so I'll let Dr. Abdel-Misih go check on that, and I'll continue to answer some questions. Can a person live without any parathyroids? No. That's a problem. If you lose all of your parathyroids, and that used to be a problem when we used to try to take 3.5 out and leave some in, that it's a real problem with calcium. The calcium can go incredibly low and cause major problems. So if there's a sense that you don't have any parathyroid tissue left, one of the common things to do is actually take a little piece of it and bury it either in one of the strap muscles that Dr. Abdel-Misih was pointing out, or you can actually bury it in the forearm. So you do what we call autotransplantation of the parathyroid. Let me just revise that a little bit. You can live without your parathyroids, but it's very, very difficult. You have to be on constant medications. So that's why we have to be very careful to not remove any parathyroid tissue that is not abnormal. That's why we went through all the fancy testing that we just discussed. Would this be similar to performing a thyroidectomy? Yes, it is. The original exposure that Dr. Abdel-Misih demonstrated to you actually is the way you would go after a thyroid as well. It would be somewhat of a bigger incision, not a whole lot bigger, and of course the dissection is a little more extensive. But the basic anatomy that we saw is the same technology. I have a viewer puts a question here. Having had an operation for this about 18 years ago, I now have to take calcium tablets for the rest of my life. Is this still applicable with your new operation? And that's basically what I was pretty much getting to, is that that means that you probably don't have enough parathyroid tissue to maintain your calcium. The incidence of this with the newer techniques is much, much lower. That's why, especially with the localization. In other words, what's changed from before is that now with the System EB scan, you get an idea where it's at, and plus experienced surgeons that are doing this all the time can almost sniff out a parathyroid. They kind of know where it's hiding. And you can't read that in a book. You just got to learn it from doing multiple cases. So yes, if you're on calcium tablets for 18 years, that reflects the state of the art from 18 years ago. That would be pretty unlikely with this operation today. Do you have any comments on that, Raafat?
No, I agree that this is probably the advantage of the minimally invasive parathyroidectomy. When you're able to do it, the chances of having what you have is, which is really hypoparathyroidism, is very, very rare, because we do not even touch the other glands. We only remove the offending organ, the small adenoma which is causing it. So the other gland should be functional afterwards. And I suspect what you had is a classic exploration in the past, and your 4 glands were all explored, either 3.5 removed, and the other part maybe did not survive well enough. But this is a rare occurrence nowadays.
A viewer, I think a young viewer, is wondering if the tool that you were using there was a laser that you were using to divide the tissues.
Well, no, this is electrocautery. So the electric current is really converted into what we call a cutting current and a coagulation current. Each mode has different purpose. The cutting current actually is could be very clean, and we tend to use pure cutting. It's almost like using a knife, but it's heated knife. And the coagulation mode is made to cause what we call coagulative necrosis, which actually, if you hold it against the blood vessel, it simply makes a coagulum, which clots and closes up the blood vessel.
So it's not a laser, but it kind of behaves like one. It's just a different technology. I think that's a very, very good question. Can you comment on the frozen section?
Yeah, the frozen section came confirming that this was indeed a parathyroid adenoma. And as I mentioned, we usually don't tell us that. Usually, majority would say hyperplasia. But this time they saw the gland we referred to, that it has a normal gland and then the adenoma next to it. and it measured, it weighed 1 gram. We do stress on the weight because obviously it tells us weight has really direct relationship to the level of calcium. So weight of 1 gram is quite high. If you imagine that the normal gland weighs 25 to 30 milligram, and this is 1 gram, so we're talking about 30 to 35 times the original size.
It looked like it was about the size of a grape. Is that?
That is correct. Mm-hmm. Yes.
Is it ever possible to remove an adenoma while retaining the parathyroid gland?
Yes, and if you noticed, today we left a little bit of the normal gland. There is no reason to sacrifice it. This is usually, as we said, benign tumor. As long as you remove it clean and intact, you achieved the purpose. So yes, you can remove you can leave a normal part of the gland.
Can you comment on how long the recovery time is and what types of side effects patients might have after this procedure? So
the total recovery is between 10 to 15 days. The first 3 or 4 days, it's going to be some form of an achy, little tightness in the throat, some discomfort in the neck. It may require taking pain medicine for 2 or 3 days. But functionally, be active, doing regular activities. We just usually advise not to lift anything heavy because that can put pressure on the venous structures. And no driving because the neck is somewhat stiff and you may not be able to look behind you while you're driving, so avoid having accidents. Overall, by 10 days, the majority of people back to normal.
And what symptoms are they most pleased to have gone from their life?
This is the interesting part about parathyroid surgery, especially in the asymptomatic patients. The symptomatic patients, like people with kidney stones, obviously you would see a good effect that you will start to have less stone formation, eventually none, if it's all due to the parathyroid. And patients who have had bone disease with bony aches and weaknesses, they will replenish their bones within 6 months to a year, and you would feel different. The ones who are actually more interesting when they come to the office, who were asymptomatic before, and yet we did the operation because of the criteria we referred to early. Some of them would come in and says, I feel different. I felt before that I had nothing, but now I felt that I must be having aches and pains and I didn't know it. I feel much better. I feel stronger. I feel energetic. So there is that element of the operation that symptoms are somewhat hidden and not recognized. And patients who have aches and pains and believe that it's just normal because of aging or having arthritis. But it turns out that at times it's related to parathyroid, and they do improve.
Another question is it still possible to have hyperparathyroidism even if the sestamibi scan came back normal? This viewer has done some research, probably on the internet, that suggests that the sestamibi scans may not all be the same. It depends on where you have them done and what the experience is. What would you recommend to this viewer?
Right. It is true that sestamibi scan is successful in picking up average 65, at the most 70% of the parathyroid adenomas. And I'll explain why is that. The arbitrary number of weight where the sestamibi scan does not pick the gland is about 500 milligrams. So if you see a patient who comes in, have the classic picture, whether you have kidney stones, have elevated calcium, elevated PTH, high urine calcium, and a negative sestamibi, that should not deter us from proceeding with the neck exploration to remove it. And we will find it. It's always there. But it's going to be different gland. It's going to be a smaller gland. That's why the sestamibi would miss it. And obviously the patients who have hyperplasia meaning all the 4 glands are enlarged. There is no major one which is enlarged and the other ones are silent. And in those cases, the system EB will be negative. So always keep in mind, 30% will not show on system EB, and we should be willing to go with the classical neck exploration.
There's a viewer here that has kidney stones and is asking if the presence of kidney stones suggests that he should have a parathyroidectomy.
No, not every patient with kidney stones will need parathyroidectomy. It's about 3 to 5% of patients with kidney stones would have hypercalcemia related to parathyroid. The majority of them is just simply have high levels of oxalate and calcium in the urine, not related to parathyroid. But it is worthwhile for any patient who have kidney stones to have their serum calcium checked, and if it is elevated, they should have PTH level checked up. And if they're both elevated, that likely is a parathyroid disease.
There's another question here about, is it of any value at all for patients to take medications for osteoporosis like Fosamax or Actinol or these medications that are available if they have osteoporosis from hyperparathyroidism?
It will improve somewhat the status of the bone, but the main treatment should be parathyroidectomy, if that's the diagnosis. If indeed there is high PTH, high calcium, and a T-score under 2.5, you can't catch up, even with high doses of bisphosphonates, and will not correct it.
Well, I think these questions are right on target. I really appreciate the viewers taking some time to ask these very good questions because they're the questions that I think everybody wants to know, because we all have aches and pains, and sometimes we get fatigued and we have a little bit of depression. And does that mean everybody has a parathyroid? No, but your family doctor, if you bring these symptoms to their attention, knows how to get you through the system so that you get the right tests and then get into the right hands. As I said, there are about 100,000 people a year identified with this disease process. So my guess is I don't know the data on this, but I'm suspicious that there are patients running around out there now with hyperparathyroidism that don't know it, and I think your family doctors can be very helpful in that regard. I also just want to reemphasize the importance that at Christiana and now across the country that we have in all operations to do this patient safety checklist. And what Dr. Abdel-Misih did for his young patient was before the surgery started, they went over a checklist with the anesthesia team. That was before anesthesia was actually started. And then right before the incision, as you saw, he went over a list of things to make sure everybody in the room is on the same page. And then the part you didn't get to see, as they closed, they had another huddle to make sure that the patient's transport to PACU would be safe. And we emphasize, want to make a point of how important that is in all surgeries for us these days. I want to thank the operating room team. Steve, thank you very much, the operating room team, for a terrific job, and my colleague and very good friend for the elegant surgical demonstration he gave us today, and thank the viewers, and goodbye. Thank you.
Thank you for watching this OR Live webcast presentation from Christiana Care Health System in Newark, Delaware. OR Live, the surgical broadcasting company.